Well, this training is being recorded. There it goes. Um, I'm gonna let Taylor and Harmony introduce themselves before we kick our presentation off today.
Thank you so much, Jose. So hi, everyone. My name is Taylor Edelman. I use he, him, his pronouns. And I have been with the National Harm Reduction Coalition for a little bit over 2.5 years now. I manage a program out of New York City. It's called the Lighthouse Learning Collective, and it's centered on queer and trans people who use drugs and also do sex work. If you want to learn more, you can go to harmreduction.org. There's lots of publications, resources. We just came out with a brand new toolkit to help organizations like the ones you work at provide better and more affirming services to queer and trans people who use drugs and do sex work. So prior to this, I've only ever worked in direct service, but now I'm really fortunate to be able to train all of you. So welcome, and I'm going to pass it off to Harmony.
Thank you, Taylor. My name is Harmony Seberg. I am the National Program Coordinator here at National Harm Reduction Coalition. It's good to see y'all again. I'm based out of New York City, and yeah, I support the national program, support a lot of the trainings that we do, and as you can see, Jose is going to be doing some shit talking today in the chat. But yeah, for today's purposes, I'm going to try and link y'all to as many resources as these guys shout out, so I can keep y'all connected to what's going on. So happy to be here.
Thanks, Taylor and Harmony. My two favorite people. So my name is Jose Martinez. I'm the capacity building and hepatitis C coordinator, and I basically deal with the hepatitis side of things and also the peer support side of things for our organization. Um, I started an initiative for NHRC called Peer Up, which you see behind me. Taylor made that. Um, but the intention of Peer Up is to provide those skills and support that, community members who are trying to, go back into harm reduction or the work force don't typically get, which means, the back to work kind of, approaches, meaning, helping people with different tools, um, the professional development side of things, they may be rusty in certain things. So, Peer Up is designed to help community members with, those gaps, helping them get those, you know, um, those skills. Um, so this series that I see we have a lot of familiar faces. This series that y'all have been a part of is funded by SAMHSA, their Opioid Response Network. And it was made to assist states, tribe organizations, and individuals by providing the resources and technical assistance they need locally to address the opioid crisis and stimulant use. Technical assistance is available to support the evidence-based treatment, evidence-based prevention, treatment, recovery, and harm reduction of opioid use disorders and stimulant use disorders. The Opioid Response Network provides local, experienced consultants in prevention, treatment, recovery, and harm reduction to communities and organizations to help address this opioid crisis and stimulant use. ORN accepts requests for education and training, and each state and territory has a designated team led by a regional technology transfer specialist, or TTS, who is an expert in implementing evidence-based practices. And if you are, looking for that technical assistance, you can reach out. You can visit www.opioidresponsenetwork.org, or you can email orn@aaap.org. just a reminder that, National Harm Reduction Coalition, we were contracted by SAMHSA. So, and a lot of our messaging can be kind of different than your typical trainers may speak. So just a reminder that what we believe doesn't necessarily mean SAMHSA believes that also. Our approach is to build on existing efforts, enhance, refine, and fill in gaps whenever needed while avoiding duplication and not recreating the wheel. So at the end of the day, all we really want when we doing any of these trainings is to provide people with a different perspective that can help build the creating, wheels that we do currently have as far as healthcare approaches and what is what has been helpful over the years and what hasn't been, and taking what has been helpful and building on those. The overall mission is to provide training and technical assistance via local experts to enhance prevention, harm reduction, treatment, especially medications like buprenorphine, naltrexone, and methadone, and recovery efforts across the country, addressing state and local specific needs. Um, and I'll remind you also at the end of this presentation, but if y'all can fill out the survey, the evaluation for this presentation, that would be really cool. Really good, be good to know what has been helpful for people, what how we can better facilitate these trainings. Um, and maybe the messaging needs to change, but we are definitely open to feedback. So what you see in front of you, this is called our North Star statement, and it helps basically guide our work. And it goes: National Harm Reduction Coalition creates spaces for dialogue and action that help heals the harm caused by racialized drug policies. So you will see a lot of us, in different spaces, maybe in capital, maybe in, virtual spaces where we're advocating for different, laws and approaches to happen. We also have our conferences. Our last one was in 2022. We decided to take a break just to figure out where we stand as an organization and conferences. And we decided to like help, and support other, spaces that cater to the community that we, advocating for. Um, we do trainings and technical assistance like this one, but we also do it for other organizations, and we offer various trainings from different topics like harm reduction to stigma, and sexual reproductive health. So yeah. And we also help organizations become opioid overdose prevention programs. And also we have resources and publications that you can access on our website. We have, webinars there that we've did back in the days, panels, and a lot of information about the community. So just a reminder, I know we are all Zoom experts by now. But feel free to add your pronouns to your name. That's if you feel comfortable using your pronouns. But that's just so like, for the moments where we are asking folks questions and, interacting with folks, I wouldn't like to, get address somebody by the wrong pronouns and stuff like that. But don't feel like you have to. But if you do, how you do that is you click your screen where you see your video, where you see everybody, and you hold your mouse over it and you click the three dots, which is called an ellipsis, and then you click it and you go to rename, and then you click that, and then you just change your name to whatever you want it to be. Um, for the moments that you aren't speaking, we ask that you do keep your mic muted because we want everybody to have as, good an experience, and not get like the background noise and stuff like that. So just, stay muted if you aren't speaking. Feel free to communicate, during the chat. If I'm not speaking, Taylor will be mindful of the chat. And if Taylor's speaking, I'll make sure that I'm mindful of the chat, so if you have any questions, comments, anything like that, concerns, feel free to use the chat. Um, yeah, and tech issues happen. So, you know, so we're gonna kick our presentation off, our session off with a question. Who do y'all feel are peers? What is a peer to you? Please, not all at once, everyone. One mic. Someone with lived substance use experience. Okay. Someone with lived substance use experience, people with similar or the same lived experiences, in this case, as it relates to substance use and or sex work. Someone you can relate to. Peers are people with lived experience just like us, folks who can connect with clients on a more person to person level rather than, yeah. And yes to all of that. Um, Peers, the term peer can be traced back to even the 1700s, and that's exactly what the term was put together for. Back when, forget the guy's name, he was a governor and a doctor at the same time in France, and he would do surgery on people, and then he would employ the people who just went through surgery to support the next person who will go through surgery, you know. And then we even look down the 60s and the 80s, and we can see like the term peers, still being used, and the whole approach of, hey, we've been, through this, let's stick together and provide each other support, you know. But then also how I view peers, now, in 2024 is I always view them as the reason why organizations keep moving. And a lot of organizations that I've been through is the peers that are responsible for um, creating and maintaining those relationships with the community. They're the ones responsible for keeping the agency informed about current happenings and the community, different change of um, maybe drug batch alerts, change of language, change of area of focus. I've always knew peers, and I'm New York State peer certified. I don't work in the role of a peer like I used to back in the days, but I was working as a peer for a few years, So, um, and yeah, the peers was always responsible for making sure everything was good. So, to put some words to it, peers who are peers, peer support resources who share similar conditions or experiences in a wide array of healthcare settings. So there isn't no there isn't a specific field where there is a peer, right? Like there isn't only peers in harm reduction, there isn't only peers in the medical field. A peer can come from different places in life. It's not only work related, So if two people have gotten hit by a car, they're peers to themselves. You understand? And um sorry for such a gnarly example, but if two people have experienced the same thing, those are peers there. It don't have to be in a matter of professional. It's all about shared experience, really. Um, so peer interventions employ a method of facilitating health promotion that encourages people to share specific health-oriented messages with members of their own community, with the goal of improving patient experiences and their continuum of care and in support of their health care. You can go to the next slide. So there's no specific field where peers are, peers are everywhere, like for the people who may even want to stop smoking cigarettes, right? There's peers in those spaces, when we talk about weight loss and eating disorders or gender affirming procedures, there's peers in all of these fields, even down to asthma management, intimate partner violence, right? Um, and other stuff. The whole point is that um in all in everything that we do, we should, as much as possible, try to include the person with the lived and living experience. If we want to see some kind of results, which we're gonna hear more later through the principles of harm reduction. Why is that important? Um, so you could go to the next slide. So I how do I explain this? Like my job isn't entirely this, but my my interest, basically, my work interest is in like peer equity, and when I say equity, that means, because the peer experience that I've known is peers being underpaid, peers being undervalued, um, peers not you know, peers not peers intentionally not being given skills to elevate in their role or elevate, period. you know. So my job has always been to advocate, for a better approach to peers and community members, right? Because when I think of peers, I think of community members, and sometimes I use the two words interchangeably, you know, and so my job is advocating for peers and figuring out different ways of being creative with the community and uplifting the community. So NHRC, National Harm Reduction Coalition, every year we submit a report to the city called the State of the Peer Workforce. And basically it's supposed to outline like the experience that the peers are going through, right? What are some barriers? And what are some ways that we can, better approach the peer workforce, right? And on one year, we decided, this was, I think, 2020. And we decided, hey, let's give more than just, oh, the peers are, being exploited. They need more money. Let's give more than that, right? Um, so what we did is we, gathered a bunch of peers from New York City, and, we was asking questions, like, hey, like, well, how do you feel about like working as a peer? Like, do you feel respected? You know, um, um, do you feel like, there's chance for improvement? Um, you know, not, excuse me, do you think that there's space for you to like elevate in your organization? Those kind of questions, the questions that mattered. And from those conversations, we created a report, and then we gave it to the city, and then the next year we did a follow-up with same thing, the same kind of theme, a bunch of peers across the city, and seeing, is this the same did anything change over the last year and a half? So from the second report, right? Um, we created what was called the Peer Equity and Inclusivity Report. So not only in this report is it naming like the barriers peers are are facing, like the exploitation and all of that, because we hear that all the time. There was also solutions in the sense of a really good template to use when trying to implement like peer workforce, like standard pay, a base pay, um a call for certain benefits like mental health, mental health benefits like we all have as full-time employees that peers don't have, retirement benefits, stuff like that, but just like different approaches and different solutions for different things. So that's where the peer equity and inclusivity report, you could go to the next slide, came from. So um after this, right, because that was just on a city level. That was only in New York City, where we had those two focus groups. I decided one day, let me see if I can do that on a more national level. Like, let's see if we could get all the peers together, and like, let's talk about it, because the thing about it is New York City is really progressive. And really, I never really seen any area where New York isn't more progressive than any other states. Like, and I'm talking about as far as like, crime leniency, um, service access, and all of that other stuff. We're really progressive compared to a lot of states. But got everybody together and we was asking those questions, we was having those conversations, but we went deeper, right? Because like the thing is that those first two reports, what that taught us is that the peers are the arms and legs of the organizations, and usually all the time. But for them to be the arms and legs of the organization, there was no support, peers being the people who were reversing the most overdoses, and stuff like that, had no follow-up support. We're still expected to do the job and stuff like that. Um, so we asked the questions, and this time it was about 33 peers from different states, West Virginia, California, New York, Ohio, New Jersey, Oregon, so many states, and we was asking them, and you know what, it was the same, and it really was worse. We started hearing more. um there is no space for, people to like really vent about stuff like this, the peers, there's none of that. We have what's called EAP, it's Employment Assistance Program, which is like the mental health side of support side of a job. Usually, the organization has like a certain number, you call them, and they connect you with mental health services, or they provide it for you right there, and stuff like that. There's none of that for peers. And we're going to hear a little bit more in a second about that. But, we learned a lot during these calls. After these conversations, what we really learned was that same story everywhere. You know, um, the peers weren't respected or valued. They were still underpaid. They were still treated, any way that they wanted to be treated, and then was thrown to the side. Um, and I thought, well, something got to be done also, you know, because we can look at a problem, but then if there's no solution, then are we really addressing the problem? You know, um, I decided that, we had to do more as far as supporting peers. This is why we have like our monthly call, the peer gathering call, you know, um, that's harm reduction focused, and that focuses on, speaking about these issues that our peer communities are facing, and giving folks a space to actually create that conversation in whatever way it looks like. Sometimes it may look like, oh, I want to put a panel together. Sometimes it look like, hey, let's do something else, and stuff like that. The whole thing is to have it a space specifically for the community, because the peer workforce, the way what we've been seeing is that it's been co-opted. And what we mean by that is that at one point in time when we said the word peer, it meant it was a person from a specific background, usually was using drugs, or not always a person of color, but primarily because that's the community that's affected by the war on drugs the most, blacks and Latinos, a person with that living experience. And then next thing we know, few years pass, and this is no disrespect, as I've said a few times in these trainings, like I have the utmost respect for somebody who puts, 4, 8, 10, 12 years into school. That's dedication, but for them to come out of 10, 12 years of school and then assume the role of a peer with no lived experience, all that told us was that the peer workforce was gentrified, and we see that a lot, Um, so you could go to the next slide. I think there's more on this page, yeah. Um, so like I said, we did the peer gathering call. So not only did we want it, because like I'm not naive, I knew that, if it's like this in New York City, I'm almost sure it's like this anywhere else, so but there was other pieces that I wanted to start, putting into play. um yeah, we had to think about, like, we have to figure out, find out, oh, is this the same like this in every other state, you know but also we have to think about networking. One of the biggest things that they've been doing to our community, and honestly, it's a colonizer's technique. It's, keep our people separated, so that there's no sharing of information amongst themselves. There's no knowledge sharing, no skill sharing, there's no, none of that, and it keeps them in a helpless place. um but networking, getting everybody together, and that, and that worked for the most part. Is getting everybody into a space, making sure, everybody knows, oh, who's in this state, who's in this borough, and stuff like that. But then not only for networking, but also to figure out what that support needs to look like. So many times we hear stuff like, nothing about us without us, nothing about us without us, and those same people, they allow other people to come and tell them and dictate what they need to advocate for, what's the best thing for them, and at the end of the day, like my intention with Peer Up and the peer gathering call is that anything that we're going to talk about, anything that we put together to address anything, it's all going to come from peers. It's not going to come from me. It's not going to come from you. It's not going to come from anybody in NHRC. This is going to be what we decide, like we as the peer community, and in this space, like, nobody who doesn't have that lived or living experience is not allowed in these calls. So like, this is really about us. So I had put together off of that last, so in total we did 3 peer focus groups, right? 2 specific, New York City specific, and then the third one was um um throughout the United States, excuse me. And then what I did was I put together like just some, from what my findings, I put together some stuff that can really like just bring everything in together where we can actually like, oh wow, okay, there's a lot going on in the peer workforce that we need to address. But these 4 points for Jose were the most important to press on. So if you could, yeah, the first point we're gonna go through is the dignity and respect, right? You could, yeah. So going back to what it means to be a peer, right? In my opinion, a peer should always have that lived or living experience and be from that impacted community, right? And this is what I mean, that, now people just anybody can be a peer. They use that title loosely. Like we hear social workers, clinicians, students, case managers, doctors, everybody say, yeah, I'm a peer. And the crazy thing is that, people genuinely believe that. And that's what sucks about it, is because now you're taken away from it. Because back in the 80s, the 90s, when people was like, I'm a peer, those was the people actually that was like the closest to the community, helping the community members or avoid overdoses, or helping them navigate through life, whatever. And then now just people who never even walked through the community, probably never even lifted up a joint of weed to their mouth, are now peers. And honestly, and as a lot of people stated on that call, as a slap in the face. you know um you could go to the next slide. you know so that's what told me that this the peer workforce is gentrified. You understand? The community members and the people most impacted are being pushed to the side and replaced with individuals without lived experience or expertise. So, and this isn't to say that, everybody, look, there's a role. Everybody has a role. And that's the reality of it. That's the best way to put it. you know there's people who could reach the community, there's people who are part of the community, there's people who are meant to address the community from a different angle, help the community, that the community members who are putting together an organization. If you're not a part of that community, maybe your job is helping them get funding or helping them talk to people and stuff like that, like. So but the thing is that everybody wants to be, you know, the um the afflicted. Everybody wants to be like, oh no, I'm part of this community, and I don't know, like. So, but sometimes your role is to just help somebody from the background. And yeah, the bike rental for gentrification. The reason why I put that picture up too, Seth, because in New York City anyway, um, a neighborhood is gonna get gentrified by those city bikes. Once you see those city bikes, you know that they're about to like start working on different projects there, start putting up condos. They did it in Harlem and Brooklyn. So, yeah. So so on these so during while we having these discussions and this focus group, right? We was putting out polls, different polls. It was like 10 polls, I think, throughout the whole thing. And people was able to answer, and we had different questions that would gauge like the peer experience. So my organization treats peers equally as they treat other staff members. You know, that question was posed in a real good time when, they was talking about how, peers are responsible for doing the majority of the work. When you see like a syringe service program or any other program, really, the people who are receiving services there are usually brought in by peers, and stuff like that. But when it came time to be praised, and all of that, here comes the executive directors and the high level folks who like don't even, communicate or interact or engage with the community, coming to receive the awards and not even mentioning the peers or the people really responsible for it. And that was like a real slap in the face, like. So no, the peers don't feel respected and valued, not with those approaches. They don't feel seen, they don't feel acknowledged, and stuff like that. um so you could go to the next one. um so the conversations with the peers showed that the organizations did not value the peer position, and if they are considered for position, the previous drug or criminal justice history is used as an excuse to underpay. So there's been there was this one person who was a peer for 25 years, doing HIV navigation, and had their eye on this on basically the position over them, their supervisor's position. They've had their eye on that position for 25 years. 25 years. saw 4 or 5 people take that role from him. Saw and he trained them. How do you train your supervisor? 4 or 5 of them. All because this person had a previous of criminal history. It wasn't even about experience at that point. It wasn't about experience and it wasn't about knowledge and education at that point. At that point, it just became obvious like, oh, you just don't respect me because of where I come from. There's no way someone been working for your organization for 25 years and you don't know who they are. You don't know what they do. 25 years. They did not respect that person. So peers have expressed frustration with the lack of appreciation from organizations. They also mentioned being looked over for job opportunities they qualify for, and it instead being given to somebody from outside the organization and the community. What they was accepted and expected to do was stay on and be, because it's a culture to pay peers and gift cards and opportunity. And opportunities don't pay the bills. Gift cards don't pay the bills. There's people that do 20, 30, 40 hours. And imagine getting 20, 30, 40 hours worth of work paid to you in gift cards. That's trash. I remember asking the same organization, I'm not going to put their name out there, but the same organization, I had the privilege of meeting their CEO. And I asked them, how would you feel if you got your check and gift cards and wouldn't even straight walked away from me? Got no response, no none of that. So what that told me is that it's acceptable for some people to get gift cards, but not you. And it's not hard. It's not hard. It's as simple as no, I'm paying them in cash. A lot of people say, oh, it's because funders. No, I don't want to hear none of that. I know so many people who they would not accept giving nobody no gift card, and they don't. What it is that people aren't willing to advocate for certain communities because there's stigma. There's stigma against people who use drugs. And then there's also the what you call that? It's called guilty by association. So like it's important to respect our peer community, treat them with dignity, respect, all of that. Why? Well, they do the most. I'm not going to read all of this out to you, but they do the most in all situations. The peers, they're responsible once again for communicating with the community, keeping that relationship strong, keeping their ears to the ground, keeping the organization informed. And then a lot of times, more than less of the times, they're also doing the paperwork and the background work, and stuff like that. This is why, like, we really go so hard for, the peers. You can go to the next one. The second piece, we was talking about peer empowerment and professional development. So we asked one of the polls, when you see these graphs, the polls, they are polls. When you see these graphs, excuse me, they're polls that we asked. So another question that we asked is, well, has the workforce gotten better over the years, the peer workforce? And it was like basically half, but the majority saying yes. And that is one point that I basically agree with, because there was a time when, I mean, I started harm reduction getting paid $200 every other week, and I was busting 40 hours. I was like very dedicated to this work, like, and so yeah, and now I don't know organizations who pay that. I know organizations that underpay, but I don't know any org that pays that. So there are a lot of pieces where the peer workforce has gotten better. There is like more recognition of the peer workforce, but um yeah, You can go to the next slide. So the thing why this is so important to me, right? This question, I am provided with training and education that will help me grow in my organization was so important to me because um all of the peers were talking about how they wanted like certain positions or there's certain places they wanted to be at in their organization that basically they didn't get hired for those positions and roles that they went for. But that means, and that solidifies my belief that now it's not about experience, it's not about education, it's not about knowledge, it's more about stigma. It's more about, oh, this person has a certain background, so I don't think we should have them in that role. And you know what? I was on a call one day where a person said that out loud. I don't want to work for anybody who's going to be on drugs. But then when they was asked like, well, what's your logic behind that? They couldn't really say nothing. Oh, they would nod off. Okay, that's not everybody. We have advocates across, like harm reduction is where it's at because of these same people who use drugs who will be too nodded off to care about the community. So we can't use that no more. Now what? What else do we have? People don't have no excuse. They only have biases, and biases aren't excuses at all. And this is what this question taught me, and what it really told me is like, so see, we have like this front where we give the peers these trainings, like, yeah, take this training, take this supervisor's training, and all of that, so that you could get a supervisor role and don't get the role. To imagine that 25, that person that was working in that organization 25 years. How much training that person must have went through for 25 years. You're not going to tell me that person was not qualified for that position. There's bias. There's a lot of bias. There's a lot of, so yeah, in some places the peer workforce has gotten better, but in a lot of places, like the acknowledgement and the respect, it's the same and sometimes worse. You can go to the next slide. So they do get the necessary training that they need to get the job done, but they don't get the pay that matches that. We saw a lot. Two people have the same role and one get paid way more than the other. And the difference in that was school. So I'm just saying, you can go to the next slide. The pay and equity part of it. There are a good number of orgs that do pay they peers cash a check and a salary. We're not gonna sit here and act like every organization pays people and gift cards and underpays people but like in general, it happens too often for to be ignored. It's a culture. It's really a culture. It's written into grants. Certain amount of monies to buy for gift cards to give. And the reasoning behind it is because they feel that they don't want people to use that money to maybe go buy drugs or liquor. But my thing is that no, when you go for a job, you work. Your boss doesn't say, hey, like I'm gonna give you this money and a gift card and stuff like that because I'm just afraid that you're not gonna use it, the way I want you to use it. Nobody would accept that. So why should we accept that from another community? So what if they go to use up drugs with it? They earned it. That's the point about it. How can you dictate the currency in which you pay somebody? It's not even the standard currency we use. Nobody else would accept that. Why should they accept it? Like I said before, there's people 20, 30, 40 hours a week. They working for the organization and imagine getting $900 in gift cards. Yo, you can't even pay rent with that. Like, but here's the thing though. Here's the thing. This is the real messed up part about that. They go and sell those gift cards, right? Because let's be honest, we need money. We don't need gift card, right? Um, so let's say they have a $20 gift card they selling that for $10. So really, they get half of that. So they not even paid like what they deserved on top of that. They not paid in the currency they deserve, and they not paid what they deserved. Also, what's even more one more time, go back one more time, my fault. Also, what's more disrespectful than paying somebody a gift card is paying somebody an opportunity. Imagine that person that spent like a certain amount of money to get to your event, to advocate for you in your event, and you make money because a lot of these conferences and events, they have like either donations or they charge registration and whatever else they charge for them. So they making money. So imagine that person that spends money to get there, only for them not to get paid, not even in gift card, but to get paid in an opportunity. Meaning, oh yeah, no, don't worry, we because you did this for us, we're gonna help you out with this other opportunity that is gonna pay them in another opportunity. Because our people, they not worth. That's how people look at our people. They not worth the money. So you can go to the next slide. So, as usual, so those decision-making conversations and organizations that matter the most, which usually is, hey, how should we approach the community? What's the best way to, put ourselves out there so that the community can better, have a better view on us? Those conversations, the peers aren't included in, which is a shame. A shame is bad because at the end of the day, that's how we provide effective servicing through knowing what is needed and then through not only knowing, because there's a difference between cultural competency and cultural humility, right? But not only knowing, but actually, moving in a way that it's not harmful at all, that is not doing no harm, that is not pushing anybody to the side, that is not, biased. There's no way we can get those kind of approaches if the community is not included in those conversations. You could go to the next, whatchamacallit, the next slide. So, and that's what it is, and this is what we mean when there's this word, this term that we as peers have in harm reduction and in the peer workforce, and it's nothing about us without us. Like, because it really embodies the harm reduction spirit, right? Where we talk about the autonomy of the individual, the inclusion of the community, and all of our practices and approaches and all of that. Like, without nothing about us without us. Um, so anyways, so the thing about this also is that a lot of peers just say like they do like their organizations let them go like to other organizations and provide like trainings and stuff like that on their behalf. And that shows that, okay, now not only is it not that peers don't have it's not that they don't have the education or experience, because they do. We saw that, right? And right now, it's not that, you feel like they can't represent you accordingly, because that was one of the questions I asked. Like, does your organization feel like you can represent them? And they said yes. A big portion of people said yes. So, okay. So now it's not that people aren't educated. It's not that you feel people won't represent you right. It has to be because of the view you have on peers, So, yeah, next slide, please. The benefits of the sport part of these conversations was probably, you could go to the next one, was probably the most heartbreaking one. Um, so benefits and support, right? When a peer takes on a job, a peer role, there's no retirement benefits, no kind of packages included with that, like it is for a majority of other jobs. There's no mental health support. There's no none of that. You know, something that a person said, they said they was living with HIV. They had to get a letter from their doctor to bring to their organization to cover them for future sicknesses, right? That was what blew. And then the peers are usually responsible for the most intense things in this field. So when we talk about like overdose reversals, it's usually the peers that's, not saying, only the peers do the overdose reversal. I'm not saying that. I'm saying the majority of them are done by peers because the majority of the overdoses reversed are from the people who use drugs, right? So the peer. Um, they do the most intense stuff, the most hectic stuff, and you know what? They get the least amount of support. They're responsible for building their own mental health support system by finding other peers or other non-peer staff. You could go to the next one. So we have facilitated the focus groups to identify the barriers that peers and community members face. So the reports like State of the Peer Workforce and Peer Equity and Inclusivity Report, they outline those barriers and best approaches to peer and community integration. More harm reduction focused support groups are needed, was also mentioned from those focus groups. Um, I'm gonna put my email in the chat after I'm finished speaking, but I can always share with y'all the peer equity and inclusivity report also, which is very important and if we want to implement peers into our workforce. And it gives a really good standard to look at. You can go to the next one. So with everything that we just went through with those 4 points, what that told me, and I hope it tells us, is that we collectively have to redefine what community empowerment and engagement means and look like. And I got the cat in the box, as y'all can see, because honestly, our thoughts need to be outside of the box. We do not need to be like the cat in this situation. Um, and what that means is that, like we can't be traditional. Traditional practices have gotten us to the point where we have 100,000 overdoses a year is a regular thing now. Fatal overdoses, preventable fatal overdoses, so we can't have the same approaches. We can't, same thing. Suicide rates is at an all-time high too, so um and we cannot meet the community where they are without knowing where they are. So, you know, a peer's role in the prevention and treatment and recovery spectrum, from providing crucial information on how to prevent and reduce risk when deciding to consume. So, helping a person with managed use, providing a level of support and mentorship and treatment, and facing the social and psychological challenges that usually come with navigating recovery. Um, outreach, outreach done through peers can better identify people with SUDs, substance use disorders, lowering barriers to accessing life-saving services through the establishment and development of rapport and trust between service provider and recipients. So the peers also, on top of creating and maintaining that relationship with the community, they also play the role of navigators in the sense of they'll be taking people to their appointments, explaining documentation and structures to people, especially if they've been through it, they walking a person through it. So yeah, next slide. Peer support plays a role in assisting patients and participants through their adaptation to treatment procedures and their overall stabilization in them. increases likelihood of patients and participants adhering to treatment and discovering a workable strategy of stabilization as problems arise. So, you know, the whole thing about it is like peers are really good at being like holding a person's hand and guiding them through, certain systems, being able to paint pictures for them before they even step into those roles. As a navigator, that was one of my most memorable jobs and probably the most satisfying job because, if it's hard going through like hep C treatment, it's hard to go through that, and to be able to like educate a person like, hey, look, this is what you look for, what was gonna happen, and because what we say one of the reasons that a person can like stop using like stop going through treatment is like if something happens like that they didn't foresee. Like, oh, sorry, you can't start the medication because you got hepatitis B, and if we already informed them of stuff like that, like there's a really high chance that they won't, leave the treatment care. So, the peers really play that role and, basically making sure them gears stay rolling. You could go to the next slide. And this is where Taylor is going to walk us through the principles of harm reduction.
So Taylor's having a little technical difficulty, so I'm gonna force him to stop sharing and I'm gonna start sharing. So just bear with us for a second. All right.
Does anyone have any questions or any statements that they want to say to Taylor or Harmony?
Taylor, are you able to come off mute? No. Okay. So maybe just log off and log back in and we'll be here. But yes, if y'all have any questions, please come off mute or come in the chat.
Questions, you're more than welcome to ask. That's those tech issues we was talking about.
Yeah. Taylor's been having to G-chat me because he can't talk in the Zoom chat or come off mute. It's been stuck in slide share mode.
That usually happen to people from Connecticut. So
Thanks for bearing with us, y'all. I can't tell if he's frozen now too. What do you think about doing a quick break, Jose?
yeah, let's come back at 2:11 or 2:16. 2:15. Let's come back 2:15. We're gonna
Right.
take a little break, y'all. Let's come back at 2:15.
Thank
That
you.
should give Taylor enough time to come back.
Oh my gosh, I think I'm back now. Wow.
Yeah, everybody's on break to 2:15.
Okay. Oh, okay. Thank you for that. Wow, I have never had that happen before. My computer completely froze and crashed.
That's how good the presentation was. It made shit malfunction.
It was so good. Well, I was like, you know what? I could log off, but I'm like, I don't want to ruin your whole flow. Everything's going so well. But at one point, everything got grayed out. Couldn't type any. I couldn't even unmute myself, but I was on camera. The strangest thing, but I'm never surprised with Zoom. I'm honestly never surprised.
Do you
Oh goodness.
do you want to try
I
and
mean,
share?
I'm.
Does that feel
I
too
mean, yeah.
risky?
Let me hop back in. I actually it restored all of my tabs. So
Okay.
now, yeah, it's opening like 10,000 windows. So let me. How strange. This is so weird. What is going on? What is going on? This is wild. This is like the ultimate sabotage happening.
It's must.
Um, I know. Everyone's like, this better be good. I don't know what he's talking about. It better be good. I don't blame you. It better be good. All right. The problem is too, I have like three windows, three screens, so it's bouncing everything around and it's disabled my main webcam. So let me go ahead and share this. Can everybody see that okay?
Yeah, I can see it. Are you sure
All right.
you want to share? Because I could also do it if you think it would help with processing.
I think it's okay. I closed a lot of stuff. So folks, just put a 1 in the chat if you're back, if you're here, if you're out there, if you're still hanging with us. Jose's spamming the chat. Nice.
Let me stop. Let me stop messing with you.
Thanks for your patience. This is exactly why we say in the beginning, we got to roll with the tech issues because as prepared as we are, and I mean, there are three of us here, stuff happens. That's what happens in the workforce. That's what happens in life. So anyway, as we get through this next session, thank you, Elena, for the comforting thumbs up. I appreciate that. So who here has heard of the principles of harm reduction? Go ahead and throw another 1 in the chat. I say a 1 because it's super easy to just throw in there. We don't have to type out a whole soliloquy, a whole sentence. And Harmony, I don't know too if you'd like to just pop in the 1-pager. So NHRC, we have like a 1-pager that spells out the principles of harm reduction. And you might be like, well, they're worded a little differently here. But we've done that, or rather, Jose's done that for a reason, because we're talking about the peer workforce, right? So we have 6 of them. Sometimes you'll see them written out into 8. And we're going to walk through all of them. We're going to walk through not only the definition, but the approach. And then we're also going to ask you some questions, right? Ask you some questions pertaining to each of them so we can really dive a little bit deeper and hear from everybody here how these particular principles, how they're resonating with you. So we're going to go into health and dignity. Then we're going to go into peer and community involvement, community-centered services, participant autonomy, sociocultural factors, and then everyone's favorite. I say that kind of sarcastically because I find that most folks tend to struggle with pragmatism and realism because they say, well, harm reduction sounds really nice. And I know it's more than just giving out supplies. I know it's also a movement, but I don't really know how to put it into practice, right? So let's just go ahead and jump right in. All right, so health and dignity at its base, I'm just going to read it. I'm not a big fan of reading off of slides, but just for if anybody is on audio only. So health and dignity, we're defining it here as establishing the quality of individual and community life / well-being as the criteria for successful interventions and policies. Right. So we're not only talking about the individual, we're talking about on a community level, how healthy are our communities? How much respect are our communities receiving or getting? And Jose went into this into detail, with the survey and going over that peers don't really feel well respected, although there might be changes and there might have been progress. A lot of folks are still reporting that they don't feel valued, they don't feel respected. It goes back to the whole bit about gift cards. I know myself, being a peer, not in substance use and not in HIV, but more, as a trans person who has run trans peer support groups. That was usually the standard, being given, oh, here's a $50 gift card, here's a $75 gift card. And it makes it very difficult sometimes to make ends meet, right? So what does this mean? It sounds easy enough, it sounds simple enough, right? When we talk about health and dignity, we say, yeah, I know what health is, but my question to you all and to our clients and our participants should be, how do they define health, right? So what I mean by that is when I worked as an HIV case manager, I would often go through my intake process. I'd go through the paperwork, right? And I'd say, well, you coming to all your appointments, you coming and meeting with me every 6 months, you having a low viral load and a high CD4 count, that's what looks like health to me, right? And that wasn't the case for everybody. And I learned that over time, of course, but people would say, I just want to pay my bills. I want to be able to live in my building. I want to be able to put food on the table for my family. I want to be able to hold down a job. I just want to be able to survive. That's what health looks like to me, right? That's more on the individual level. But when we're talking about a community level, right, what does that mean? And that's the question I'm posing to you. If you could put in the chat, or if you're feeling rather saucy and you want to come off mute, what does community health look like? We're not even talking about the dignity aspect, but what does community health look like? How do we know if our communities are healthy? Are there certain data sources we look at? Are there certain reports that we look at? Is it just word of mouth, feedback? How do you know, or how do we know that our communities are healthy? What are the metrics? What are the parameters? Right? So I'll give a second for that. I'll give about 10 seconds. So that's my question for you all. How do we know that our communities are healthy? Yeah, Elena, go ahead.
Hi, sorry, can you hear me?
Yeah, you're good.
Okay. Well, I was gonna type, but it was a lot. So I think how we know if it's healthy is if people are accessing the resources in their community. I think especially in LA, there's like a lot, like maybe an overabundance of resources sometimes, but like programs see that not a lot of participants are utilizing the programs or taking advantage. And that goes to say, like, are these people being overworked? Do they have enough money to even go to events like this? Is it an accessibility issue? Like, if people aren't using the resources, that means that maybe something about the community isn't healthy, or there are other I guess barriers to accessing resources that maybe we're not aware of.
I love that. Thanks for coming off of mute and sharing that. Are there other folks that kind of agree with what Elena is saying? And I love that you brought that up because it begs the question, okay, are we oversaturating? Are we overwhelming people? But also, are the measures or the metrics that we're using to identify a lot of these barriers, are they also the problem? Because again, a lot of times I would say to people, well, you didn't come to your appointment. You don't care about your health, right? Which is a terrible thing to say. And I was like a crappy case manager in the beginning because I was going very by the book and by the intake and all of this, right? Being like 23, 24 years old and just kind of being very by the book. And people would say, look, dude, I don't have time, right? Every time I come and see you, I don't get paid time off, right? I worked with a lot of folks who were monolingual Spanish speaking, who are immigrants living with HIV. And they would say, you know, I come and see you on the rainy days and I call you on the fly because I don't have time to come and see you. Time is money, and then I'm losing out on opportunities to get paid. That's why I don't come. It's not that I don't care. Just as Elena, you were saying, your resources are not accessible for me, right? The way that your program is structured is not accessible to me, right? So it's sometimes looking a little bit deeper at our programs and being a little pragmatic and being real. And that also has to do with the way that we treat people. That's respect, that's dignity, right? We want to center that dignity, right? You know, I think about this too with when I was working with folks who would say they'd come into their appointment and I'd ask them to fill out paperwork and they go, I forgot my glasses. But it was every time they forgot their glasses. But what happened is that they did not know how to read the documents, right? There was a huge problem with literacy, not even medical literacy, right? The doctor would talk to them and their eyes would glaze over. And that was one source of support, was having me there, having a community health worker there to say, you know, this is what the doctor would like you to do. Do you have any questions? How do you feel about this? Right. And it was our job to try to figure out resources or ways to overcome those barriers, right? Is it just simply your prescriptions are not in Spanish? They're not in the language that you need them to be? Are you confused about which medications to take, right? Are you not sure when you have to get your lab work done? Do you need a medication treatment adherence nurse to come? All of these things, right? But we would never know if we didn't know how to structure our questions differently and ask. And that's also why we have life is unpredictable on here, because our needs, we have competing needs. It goes back to what you were saying, Elena. There could be too many resources and that person doesn't even know where to start with everything. So this is where our approach comes in here. How can we have conversations that come from a place of compassion, right? They come from more of a loving place and they're less rigid, they're less medical kind of professional. And that's not to say, I don't want people to think that if they're less professional, they are not appropriate, right? I think there's a way to connect as a human being and not have to sit there and read off everything. Like, you know, at a certain point, I put the pen and the paper or the laptop down and would just have a conversation. And after having a conversation, would fill out my intake paperwork, which sometimes was like 20, 30 pages. I don't know how many people here have intakes that are 20, 30 pages, but that's typically the norm. I just trained at a housing program in New York City yesterday. Their number one question, Taylor, how do we trim down our psychosocial assessment? It is 30 pages long. Who is going to sit there and fill out 30 pages and feel like you're treating them with dignity, with respect, right? That you're meeting their needs. So these are just some other questions to prompt you. You don't have to answer them now, but these are just things to keep in mind. So what are ways that we can also get people to identify and build on our strengths? This could be maybe where motivational interviewing comes in. Put a 1 in the chat if you know what motivational interviewing is. It's basically, you know, a strategy that we use that anybody can use. It's not just clinical. Okay, good. And it's for people who are maybe on the fence about making a change. It could be maybe they'd like to stop smoking. They're interested in exploring that. Maybe they want to stop using other drugs. Maybe they want to leave a problematic or abusive relationship. It could be many things where we're looking to help them and guide them through a behavior change, right? All right, so peer and community involvement is really, really big. So this prioritizes giving impacted community members a real voice in the creation of programs and policies. So my question for you all is, how many of you have community advisory boards or something that looks like a space where clients, patients, participants can actively give you feedback? It could kind of be a focus group. It could be surveys. I know a lot of our grants or maybe the funding that you get, they require them, but I'm really interested in what you all have available. So go ahead, put that in the chat, or you can come off mute if you do something a little different. You feel like you have a different flavor to what's going on too. So nobody has a CAB, nobody has a community advisory group or board or anything. And they're simple to put together. Yeah, Elena, go ahead.
Yeah, where I work at now, currently a caseworker for HIV positive individuals. And I'm in California. A few places got this grant called the End HIV Epidemic Grant. And they saw that a lot of people weren't engaging with the program, even though it gives incentives basically to get undetectable. And people are like, why aren't people engaging in this program? So that's when a CAB was developed, and we got some of our clients who are in the program and some clients who aren't in the program because they didn't qualify. But they like gathered them and asked like, okay, so what do y'all what is it engaging about this program? What do y'all need from this program? And what are some outside events that could attract people to this program? Not necessarily just like getting people to come in, but like events where they can have community spaces to gather, like parties. Like how can we promote this without it just being clinical, but it being like a space for people to gather and meet each other and find peers that way, which I think is pretty cool.
That's awesome. So I love that that kind of rung a bell for a lot of folks being like, okay, how can we engage people? Oh, all right, community advisory board. Maybe let's provide some different incentives. Let's provide food. I'm a big fan of if there's food, people will come. We used to do that with community advisory boards. And Seth, to answer your question about what my question is, I was just asking and wondering, was curious if anybody here has a community advisory board, which are typically used to engage, just like Elena was talking about, to engage folks in the community, people in our programs, because that can be a really great way when we're talking about peer and community involvement to hear from folks who are directly impacted, right? And as it says here, a lot of times orgs will create policies and programs for the community without actually including them in the implementation process. I actually saw, I was looking at the USCHA. I don't know if anybody, well, everybody's here. I'm assuming you're not at that conference, but if you know folks who are at that conference down in New Orleans, it's like the big conference dedicated to HIV and AIDS advocacy and programming. But basically there was a session that said, if you do not, to the effect of, if you do not include trans women, right, you are not going to end the epidemic, right? If you don't include our communities who are directly impacted, there's no sense in having this plan by 2030, plan by 2040. And you notice how it always moves another 5-10 years because what we're doing is not working, right? Ryan White funding, it's the second most funded federal program. Think about the millions of dollars being dumped in. But what we're not doing is addressing people's basic needs. I know because I worked in case management, and sure, I had housing vouchers, I had bus tokens, food pantry thing, but these were all band-aids and they weren't actually giving people what they needed. It was what our program wanted to give them so we could say that, okay, we did our job, we're going to get more funding, right? And I'm sure that's the case for a lot of other people too. And that's also why community needs assessments are really crucial. Most states or counties or regions do them. They're very, very lengthy, but you could even do one in your program, create one, a little like 1-page thing, maybe have some funding, incentives behind it and be like, what do you need, right? And you could work that into a CAB or a community advisory board. The thing too that are certain things to watch out for with this particular principle is this idea of tokenism, right? Sometimes in spaces we're just looking for a certain identity and we're not really caring. We're just saying we need to fulfill or check off this box. So, you know, we need to have a trans person in here. We need to have someone living with HIV or Hep C. I know I was in a particular situation where at a previous org, they said, well, you're trans, can you run the trans peer support group? And we had a lot of trans women, femme presenting, non-binary folks, right? And me not identifying as such. I'm like, I think we should have different groups. We should have different affinity spaces because not everybody's going to identify, right? But to them, it was dumping all trans people, all gender nonconforming and non-binary people into one group and saying, now play nice and work it out, right? Treating us as a monolith. And unfortunately, that happens a lot in other spaces too. So again, like it says here, the peer community advisory boards are super important because we know that impacted peers have really deep insights. They have really meaningful things to share, right? Different perspectives to share. And that can even differ across those peer groups, the people who are in the room, the people who are there, right? And the other piece of this too is that although we want to create spaces for peers, we need to be able to provide the resources and tools, right, for them to be able to do their job successfully and effectively. I don't know if folks here identify with this, but many, many times we'll have peer programs. We will have specific roles for peer navigators, peer coordinators, and we'll say, okay, you have lived or living experience. You can go out and see folks. You can do outreach. You can counsel people. And then what happens, this is not in all cases, but I've seen it in many, is that that person, that peer is triggered, right? Because they weren't given the tools to be able to maybe cope or de-escalate. And instead we have problematic behavior or things that are deemed problematic go on. And I've seen that in some trans peer spaces, right? Where somebody is maybe newly transitioned, they're forced into a peer role. They didn't have the support, they don't have the support at the organization, and they potentially get really triggered or they cause harm to that person that they're trying to provide services to, right? So that's also a big thing. So this one, peer community centered services, it's just being non-judgmental, right? It's non-coercive. We want to give people services and resources, right, in the communities in which they live in order to make sure that they have what they need to reduce that harm. So what does this look like? What does it mean? We're going to go a lot further with our community if the approaches actually meet the needs. So it goes hand in hand with what we were talking about with the community advisory boards, right? If we ask people what they need, we can therefore match those approaches. And this happened a lot with COVID. COVID forced us to reevaluate our outreach efforts because the community needs look different, right? People were isolated, they were feeling alone. If you've seen our Foundations of Harm Reduction training, we talk a lot about the continuum of drug use, right? We talk about how during COVID, sometimes this exacerbated use, people felt socially isolated, they felt alone, maybe they were using a little bit more than usual, right? And then things changed when restrictions started loosening, things started opening back up. Although I will say is that we are absolutely not in a post-COVID era. We are very much still in a very, very dangerous time with regard to COVID. I mean, just look at the wastewater reports. I'm sure we all know people who have COVID or have had it recently, right? So what this also looks like too is going from point A to point B. It might also have unexpected pit stops. There might be bumps in the road. There might be barriers. There might be things that come up. There could be accessibility issues, right? Are we offering services in community spaces? Are we offering them in offices? Are we going mobile? Are we going street-based, right? Are our programs only allowing people in if they are abstinent or abstaining from using drugs in any way, or only certain drugs or certain substances, right? So some things to think about with regard to our policies. So again, a lot of this goes back to those spaces. It doesn't have to be a CAB, but I feel like it's very helpful. I mentioned the surveys, questionnaires, things of that nature. Peer programming is also a really great way to connect the organization to the community. But again, like I had mentioned a few slides ago, ensuring that there are supports, that there's proper onboarding, that when somebody comes into the organization or the program, they're not just dumped a bunch of stuff and said, sift through it if you want. We're going to hit the street tomorrow and it's all good. There's no shadowing. There's no anything else that goes on. There's no respect there. Peer autonomy. So peer autonomy affirms the individual as the primary agent of change and seeks to empower communities to share information and support each other in strategies which meet their actual conditions of harm. Not what Taylor thinks, not what Jose thinks, but what are their actual conditions of harm. And this can look different for many, many people, because as we'll talk about, I believe on the next principle, we have interlocking oppressions. We have differing oppressions based on race, ethnicity, gender identity, socioeconomic status, disability status, right? Many, many things. So what we want to do is say, I'm guiding you through the process. I'm not telling you what to do. I always like to phrase it as kind of offering a buffet. So you can say, hey, if you want treatment, this is what it looks like. These are the really cool resources that I've vetted. If maybe you need an affirming provider, right, for gender affirming care, you can go here, right? If you want PrEP, you can go here. If you need PEP, here's this hotline. If you need mental health resources, this is what it looks like. These ones engage law enforcement, these ones don't, right? It's just offering a plethora of resources to make sure people can feel empowered, right? And when they feel empowered, they can then support others, right? So we ask them, what are your priorities? What are your values? What do you want to get out of this interaction? It's not just what I want to get out of it. Is this for yourself? Is this for your community, right? And how can we meet the person where they are, but also not leave them there? Right? I'm saying, okay, I'm just glad you came in for the visit. And I'm not leaving it there. I'm saying, I'm glad you came in. We can do X or Y thing, right? What skills do you have, or what skills do you need to be able to propel you forward to be an agent of your own change? But also for us to think about what happens when we can't be there to support them. I think about when I left my role as a community health worker and as a case manager, and some of my clients were really upset. And I said, I don't know how I'm going to do this, or I don't know how I'm going to do that, right? Sometimes we, to the best of our ability, we try to avoid that scenario by giving them everything that they need to be able to update their Medicaid paperwork, right? Or their state insurance paperwork, or, be able to put together their financial statements, but sometimes not, right? And that can sabotage people or set them up for failure. So you have to think about those things too. So it goes back to when you're meeting with folks, listening to them. What do you want to get out of this? What do you feel like you need to work on, right? But there's no shame in also saying, all right, I'm hearing that. However, based on this and this and this, I would say to people, all right, I got your lab results back. Your viral load bounced up. Your CD4 count's a little bit lower, or you've missed the last 5 visits with the provider. Maybe this is something we can work on, right? You're telling me you need a bus token, right? Which is great. I want you to come see me. I want you to come see the provider. I want you to come get services. But what's the barrier in between these things? That's what I'm identifying as a possible opportunity area, right? There's no shame in saying that, because you're providing people with those life skills to be able to promote their health, right? And you're treating them with dignity. So maybe it's setting an alarm, right? You have specific appointments for things. You're going with them to appointments if you can, right? You're sharing their goals. You're being open. You're being transparent. but being really mindful that our expectations don't actually get mixed up with their goals, and I'm influencing it. And I'm saying, these are my goals for you, rather than them saying, these are my goals for myself. So sociocultural factors, they recognize that the realities of various social inequalities affect both people's vulnerability and capacity to effectively deal with potential harm. So what does this mean? That's a lot of words to basically say that the environment we live in and the culture that we're part of, right, they can have an effect on our outlook on many things, like education, like healthcare, like employment, like circumstance. I always give the example that me, as a white middle-class transmasculine person from Connecticut, has a very different experience than a Black or brown trans woman growing up in the Bronx, right? But yet, as I said earlier, I was supposed to be leading a group, right, to represent these identities, which was not always the most appropriate thing, because we didn't have a lot in common, right? Because we walk through the world differently. We didn't have a lot in common other than the fact that we identify as trans people under the umbrella, under the spectrum, right? So sociocultural factors too, they take into account all the stigma, all the biases, all the societal norms, because, you know, if you're trans, if you're queer, if you're somebody that uses drugs, if you do sex work, society does not speak kindly about you or to you, and does not make you feel terribly empowered, right? So that's why it's so important for our programs to realize that our movements run parallel to one another, right? Our focus areas, whether you're talking about HIV, whether you're talking about Hep C, whether you're talking about drug use, whether you're talking about sex work or gender affirming care, all of these things can be boiled down to bodily autonomy, the right to do with your body what you feel is appropriate or necessary for you to do, right? And we know when somebody moves from one lifestyle to another, maybe they're using more, now they're using less, right? They're coping with the tools from what they know. So the approach here is that we have to ask, what are tools we can provide to the person to help them stay grounded and overcome really difficult, or what we call trying situations? We need to promote awareness, education on issues related to inequity and cultural humility. Put a one in the chat if you've been through some form of cultural humility training. Sometimes they'll be called cultural competency, although cultural competency is different from cultural humility. And actually, Tanagra, who you might have seen in some of these sessions, runs a cultural safety presentation, which is excellent because it takes things a step further. Because when you're talking about safety, it opens up the conversation, right? And it's more than just, hey, this month is Recovery Awareness Month. Hey, this is Pride Month. We're going to do this thing. What's your commitment to our communities 365 days of the year, right? And part of that is encouraging community involvement, encouraging that advocacy to make a change, right? Empowering our clients and our participants and other peers to say, you can go to the Capitol, right? Here is our organizing campaign, right? Here's our advocacy. We're trying to pass this bill to get more services or to get more funding for you all, right? It's just a really awesome thing when you're able to really meaningfully involve the folks that you're serving, right? It gives folks a sense of greater purpose. So last one here, I did say in the beginning, pragmatic and realistic sometimes people struggle with, because harm reduction can kind of seem like this big nebulous thing. But pragmatic and realistic doesn't attempt to minimize or ignore. There are real and tragic, and sometimes fatal, dangers associated with using drugs, right? Whether they're illegal or whether they're legal, right? And other risk behaviors. We know that. The difference is that we are very pragmatic. We're real. We're acknowledging that people are going to use drugs. People have always used drugs, and people will always continue to use drugs, right? Life happens. It's happened to people. There are a lot of different situations. There are a lot of circumstances that our community members have gone through. Often when I'm training, I kind of talk about it like a backpack, right? What are people coming in their backpack? Is it family trauma, right? Is there a family history there, maybe of mental health issues, right? Is there economic disparity, right? Is there a language barrier? What are the things that our folks are coming in with? Oftentimes we see them for maybe half an hour out of the day. What are they doing? What's the environment or context that they're existing in all the other time when we're not seeing them, right? And we have to also acknowledge that people might still be living in their previous lifestyle when they're trying to transition to another one. So there has to be grace given there too. It's not a simple switch. I'm feeling this way today, I'm going to be totally different tomorrow, right? And like I said earlier with the definition, we know that using drugs can have some really serious consequences, right? But it's not just saying to someone, well, cut it out. If you know that's bad for you and it's hurting you, then cut it out. What if they're using drugs to stay up? What if they're using drugs to finish an exam, just get through work? What if they're using drugs to cope with trauma, right? To kind of dissociate or take themselves out of a situation. Also, what about just using drugs because they feel good and you like them, right? There is no shame in that either. And that's a conversation that's also really important to have. And the last piece here is also acknowledging that advocacy can have negative effects. Again, you could be over involving and you could be overworking people. And if you have community members who are attending things on their own dime, try to pay for them. When we do an advocacy day, like the last one, we did an advocacy day for the decriminalization of sex work in New York. We paid for transportation for buses to take people there, to take sex workers there and other community advocates, right? And we also provided them food, right? We really want you there. We need your voices. Come stand with us. And I think there were almost 100 people that attended, which was amazing. So going back to this last piece about pragmatism and realism, that also means acknowledging that all of these concerns and all of these approaches are valid. It's not up for me to tell somebody how they feel is not okay or it's not good, right? But it's my job to guide them through, not to rescue them, but to guide them through and make sure they have what they need to succeed and also move forward in life, right? Okay. So that's what I have for all of you. A little bit early, which is great. So we have time for any questions, or maybe this sparked something for you and you're like, I'm curious about something Jose said about an hour ago, but I didn't want to ask it. I didn't want to ruin his flow. So we'll sit on here for a bit if anybody has something they want to share. And thank you, Harmony, for sharing the survey. All right, just so I can see everybody again. Okay. All right, thank you, Ravina.
No questions. No comments.
Thank you, Seth. Yeah, we'll
That's
hang here
okay.
for a few minutes.
Okay.
Put my email in just in case somebody wants to ask something. They don't want to do it here. Thank you, Elena.